Good evening. I just want to first of all take this opportunity to acknowledge my colleague from the government of Kenya, Dr. Nduku Kulonzo, who's come along with me, and it's to show that how the public and the private and the UN partnership is working. But at the same time, Philips and Merck and GlaxoSmithKline, I don't know if they're here, Safaricom, Huawei, and the Kenya Healthcare Federation have really been a part of an ecosystem of change. So let me give you a bit of a background. Back in 2014, the government of Kenya launched what is called a free maternal health care policy, and that was purely driven by the fact that Kenya was seen as the amongst the 10 most dangerous countries for a woman to give birth. The maternal mortality ratio was close to 488 deaths per 100,000 live births, and there are counties in northeastern Kenya where the maternal mortality rate was as high as 3,795 deaths per 100,000 live births. For the persons who, just to kind of give it a correlation, in wartime Sierra Leone, it was 2,000 deaths per 100,000 live births. So you can understand that the challenges of reproductive maternal and child health was huge, and that's the reason that the government launched this campaign. Clearly, the MDG goal of MDG number 5 was not met, and that was why there was a sense of urgency put to it. Now, I came there at the time when the UN population, as the head of the UN Population Fund, and we wanted to understand where the problem really was. So we went county by county trying to understand the data, and that's when we got to understand that 15 counties of the 47 contributed to 98% of the maternal deaths. So we knew where the problem was. It also defined the health inequity, the brokenness of the health system in places, and just the sheer absence of the facilities that you need to advance reproductive maternal and child health. And why am I saying that? To me, ladies and gentlemen, the reproductive maternal and child health, the issue of sexual reproductive health and rights is central to universal health coverage. We don't get that right, we don't get UHC right. So when we started this program, we looked at who's doing what where, and led by the Ministry of Health, we identified 6 counties, which are in northeastern Kenya: Mandera, Wajir, Marsabit, Lamu, Isiolo, and Migori. They may not mean much to you, but Forbes recently, which couldn't spell Mandera, actually wrote an article about the changes that are happening in Mandera and the dramatic nature with which changes are taking place. Incidentally, in the last 2.5 years, Mandera County went from 3,795 deaths per 100,000 live births to 550. Now, if that were to be tried in India, where I come from, it would probably take 10 to 15 years. So that is the scale at which it is changing. And why is it changing? And that's clearly because what we wanted to do was, when Philips came, and actually Tees is sitting here, he'll be speaking to this tomorrow, he came to me and said, "Oh, Sid, we need to do a program with you. Why don't we go do something in Nairobi?" I said, "Tees, you know, this is not where we need to be working. We need to go to these northeastern counties." And I commend Philips and all these companies that decided to come along. And we went to Mandera for the first time. The day we landed there were about 36 Kenyans who'd just been killed by the Al-Shabaab. And that was the moment, I think, change started to happen. We arrived there very much committed to making sure that we have to do some transformational work. Again, the leadership of the First Lady of Kenya was crucial, because she started what was known as the Beyond Zero campaign, which was really to end the scourge of PMTCT and the challenges that children face, because there are 3 H's that kill women: HIV, hypertension, and postpartum hemorrhage. All preventable. And it was a matter of what would we really do to come together to transform that. And a small amount of funding from a trust fund, which came out of UNFPA, about $15 million, we were able to bring Philips and GlaxoSmithKline and Safaricom and Huawei, a Chinese company, the Kenya Healthcare Federation, and Merck, and essentially look at what could be done in that ecosystem with the county governments, with the national authorities, but clearly a leadership of the government. And these partnerships came together, and just a small action of looking at social media interventions, where really making them aware, these county governors being made aware of the responsibility that they had, we saw a convergence of what I would term as the 3 Ps. Political will, that was paramount. Without that, we could try our best in any country. If you don't have the political will at the highest level, it's not going to happen. Second, the right public policies were in place. It was about how the UN system with the government could actually ensure that those public policies were translated into action at the remotest village. And the third was partnerships. Now, this partnership meant an unorthodoxy of partnerships, not the business as usual kind of partnerships that we are, oh, you know, Gavi's giving some money to UNICEF. I've served in UNICEF for a long time, and, you know, this is being done, and the private sector being seen as a donor. No. There was no corporate social responsibility on the table. This was about what could be done together to transform the health system. And this is what happened, that in a matter of 2.5 years, through demand creation, through capacity development at the county level, the best technical staff being put there to help the counties deliver, the last dollar being tracked. We got Deloitte to do the report, and the current Minister of Health launched that report in New York very proudly in 2016, where 6 counties made a dramatic change. And in 2017, at the World Economic Forum, where we were invited to present this, a decision was taken that we need to go for UHC. If we can do it in 6 of the most difficult counties, why can't we look at universal health coverage, but the preventative side? So what happened then was a decision was taken by the government, and the government came up with what is called the Big Four agenda: universal health coverage, food security, affordable housing, and manufacturing. Ladies and gentlemen, let me remind you that to reap a demographic dividend, which is where Africa is at, the median age of the country, of the continent, is at about 18. Over 70% of the population is less than 35. If you look at the scope of Western Europe and how they evolved through a Marshall Plan, and how the Asian tigers evolved and taking advantage of their youth, taking advantage of people being put to work, that is the scale and ambition that we need for Africa. We get that right, and the investment has to be in accessibility to quality healthcare, accessibility to quality education and skills. We get this right, Africa becomes a future market for an aging Asian tiger and an aging Western Europe. The demographic trends are clear. Tim Evans explained that very adroitly. The issue now is, how do we take advantage of that? We cannot afford to have an Africa which starts to age before it gets rich, which is what happened with the rest of Western Europe. They all got rich before they got old, and like the same is the case with the Asian tigers. This is exactly where it is. Just to tell you now finally that the scope of health business in Africa is projected to be $280 billion. That's not my figure, that's the figure from the World Bank and the Africa Development Bank. The scope of agribusiness in Africa is projected to be $1 trillion by 2030. The scope of the consumer market is expected to be $3.5 trillion by 2030. However, every day, 40,000 Africans are joining the workforce, looking for work every 24 hours. 10 to 12 million African youth are looking for work every year. We are barely creating 2 to 3 million jobs. And if we don't do that, then what you saw coming out from Yemen and Syria and the West kind of hurtled with the scourge of migrants which they couldn't handle. Imagine what will happen from Lampedusa when millions of boats come your way. So you've got to keep those things in mind. The largest migration took place from Ireland and Italy because the state did not work, because there was fragility there was impoverishment and poverty there. But we can reverse that very quickly. And this is why the critical nature of the private sector coming in with the government and really looking at partnerships which can help to leapfrog the healthcare system. And I'm talking about leapfrog, not a slope of an upward curve. No, that's not the trajectory. We have the technology, we have the wherewithal, we have the means, we have the human capital to be able to leapfrog that. So essentially, what we've seen happen in Kenya is the public-private partnership has worked. What does it mean in going to scale? That would be a question which is open, and I hope the next 2 days would allow us to deliberate that.
Thank you. Terrific. Thank you very much.